So, good afternoon. Welcome to this episode of Challenging Conversations. Origin of the Challenging Conversations series is we started at the Maudsley Hospital in South London. We wanted to provide a safe, psychologically safe, open forum place where our patients, our experts by experience, their families, our clinical staff of all types, our managers, members of our local community could openly debate some of the difficult, challenging, hot topics in mental health today. So we've had episodes which you can watch on our YouTube channel about restrictive practices in mental health. Why do we train people to do it if we don't want it to happen? Medication, great episode with Sir Robin Murray saying we know that medication is can be a very valuable adjunct to treatment for people, but do people need to stay on it long term? We've had other series looking at the impact of racism as used in therapeutic practice. Is racism really an adverse event that we should be mindful of as we go through the practice of psychiatry? So those are the kind of topics we've covered. Today is different in the sense that today we are incredibly privileged to have with us Professor Tim Kendall, who's the National Clinical Director for Mental Health, and Roberto, who led so many of the movements to a very different model of community mental health care in Italy. We have Livia Martucci, who is a clinician that is bilingual. She's Italian, but is working in England. So she's going to tell us about some of the challenges and the great opportunities around mental health. And then because we like to remain grounded to our true purpose, we have George, who is a trainee, senior trainee at the Maudsley, and who's going to talk about in his 7 years coming from Greece into the NHS, what does he see as the challenges? I am really, really devastated that today, unfortunately, our wonderful expert by experience carer who had wanted to join us cannot do that for kind of family emergency reasons. But we will, believe me, we will come back with her perspective in our subsequent webinar interview series. So can I kick off today with Tim? Tim, you are very, very welcome. Wonderful to see you on the screen, and take us away. What's the plan for the future for community care?
Okay, well, I'm just going to give a little bit of background to what I'm about to say. When I was a junior psychiatrist, I've been 2 years into training. 1986, I went off to Trieste. Now, at that time, I was working in an asylum in Sheffield, as well as a new psychiatric unit there. We had about 2,000 beds. And I would say that in the asylum in particular, but I think across the board, violence towards patients was endemic. And all you had to do was to get involved, setting up community meetings, that kind of stuff and you'd hear it from the patients. And in doing that, I discovered that there was a prostitution network run by one of the charge nurses. I had a patient die of starvation. And, I could go on. I published some of this, by the way. Now, when I was in Trieste, it couldn't have been more different. There was this, historically very thoughtful place that had shut the asylum, but they brought the community into the asylum. So you go in there were cafes, there were theatres, there was places you could make music and that kind of thing. And they'd taken what was in the asylum, put them out in the community. So they had, restaurants that were run by service users and stuff like that. And they had community mental health centres, about one for what we would think of as a PCN, one mental health centre for about 50,000 people. And they were doing crisis work and work projects and that kind of stuff. So it was phenomenal impact for me as this junior doctor, thinking, oh my God, could this really be possible that you could do community psychiatry? And I have since that time had that at the back of my mind for most of the things that we've been planning and done, both in my own trust in Sheffield, where as a medical director, we managed to bring down the number of beds by 95%. So we went from 2,000 down to less than 100 beds. Now, what are we doing nationally? I took over from you, Geraldine, in 2016. We managed to get, in 2016, we got an extra £1 billion to spend, not much on community. But in 2019, we all realized this was an error. And we got £2.3 billion extra to spend mainly on community services. Now, out of that 2.3 billion, so it's 2.3 billion per year by 3 years from now. So it's gradually working up, and we're halfway through it now. So by 23-24, there will be effectively £1.3 million for every 50,000 people to spend new on community mental health. So this could not be a better opportunity for us to think about what we do. Now, the instructions that come with that 1.3 billion are that we need to have place-based care. So we need to focus on the community. We need to get rid of the difference between primary care and secondary care. That we need to provide psychological therapies that have got good evidence for their effectiveness. That we don't turn people away. We have a no wrong door policy. That we trial waiting times, try to get them down to about 4 weeks if we can. And to do this, we've had for the last 2 years £70 million, which we've spent on 12 sites to try out how you could do this. And every one of those 12 sites has done it differently. But I would implore people now to not only look at those 12 sites, but get into an aeroplane or a car and go out to Trieste, maybe stop off at Lille en route, and maybe one or two other places, and just think about how you could deliver your new £1.3 million per every 50,000 people. And think about just how many beds we've got now that we might be able to do without. So although in Sheffield we might have less than 100, nationally we've got about 24,000 beds. Now I think we could do with far, far fewer of those beds if our services were really, really sophisticated and thought through and engaged and getting into helping people early. Now, on that note, I think I'll stop. Admitted, I'm a huge fan of Trieste. Think it's possibly the best mental health service I've ever been to. I'm not saying we should do the same. I think we should do it our way, but let's not ignore examples of best practice.
Thank you, Tim. What a great rallying cry. For every 50,000 population based on their primary care networks, there's an extra £1.3 million to spend. What a great dilemma to have. How can that be done? So, Kieran, can we get Roberto on the panel? Is his signal coming through from Trieste? It was earlier. Hi, Roberto. Can you hear me?
Yeah. Okay. Thank you. Sorry. Geraldine, thank you very much. Thank you very much, team, for this great introduction. I have, a very difficult task to try to summarize in a few minutes some information about my experience. I was very lucky because I spent the whole my career in Trieste with a great companions, group of companions and leaders. And then over the last few years, I became the director of the services, and I retired less than 2 years ago. But I hope the situation will survive after COVID, which is a terrible, storm everywhere particularly about community-based care. But the system is very solid. So it started with the idea of replacing not just the psychiatric hospital, but creating the alternatives in the community by responding to the needs of those who were discharged from the hospital. So we were focused all the time about pathways of care, and more than care, probably the idea of providing a whole life response to the needs of these people. So the idea of working with the help of the law that started in 1978, also following the example of Trieste, Arezzo, and Perugia, were the three leading experiences in Italy. And the law, as you probably heard, is still there after more than 40 years. It closed the psychiatric hospital and provided a framework, which is important to underline, which is favoring the use of no restraint system of care, because it's a very limited possibility of providing compulsory treatment, voluntary treatments. They can be done also in the community by community mental health services. So the use of new institutions, the creation of new institutions was very limited by the law itself. Today we have a very patchy situation in Italy. Trieste is still somehow the avant-garde of a certain way of doing that is based on a full accessibility. So I think the pathways of care starts with the possibility for each person to walk in a community mental health centers without any referral, just self-referring to the mental health center, or the family can do that, and asking for a solution of the problem and explaining the story and the social circumstances, the life events that happened around the crisis. And from the crisis, there is a continuity of care all throughout the system, which is guaranteed by the same team. So the team is based in community mental health centers, as a team said before. These are rooted still in limited, in very small, and we can say catchment areas of about 60,000 inhabitants maximum in Trieste and in the region Friuli. These centers are open 24 hours 7, and they have beds for respite. We can say even more than respite, because they can manage also difficult situations and even involuntary treatment with the open doors. So being with the people in crisis. And of course, the system is completed by a small 6-bed unit in the general hospital that covers 500,000 population. And it's very transitional, so we don't use the beds as places for a proper medium-term hospitalization, but they are just passing through the system and being referred as quick as possible to the community-based services. The system of care is complemented by rehabilitation opportunities, by, for instance, social cooperatives that provides opportunities for work. They are enterprises that are rooted in the community. They provide services to the community. There are a number of associations of carers and people using services, which are providing also pathways of social inclusion at the same time. So the system is based on responsibility on catchment areas by discrete teams. These teams are working as a unity. They try to develop a culture. A common culture is not just the sum of multidisciplinary figures, but it's a whole culture that has been developed. And this team try to provide a project for life for the person who comes in touch with the community-based services. The system has been scaled up to the region Friuli, so now it covers 1,200,000 with the same, so you can go everywhere from Udine to Gorizia to all the cities you can find in the northeast of Italy, but hardly diffused in the rest of the country because of number of resistance. Even if the parliamentary commission say this is the model for the country, the family organizations are claiming to have that everywhere. And this is not expensive, because if you calculate the cost, it is, we calculated recently, it's just a little bit more than 1/3 of the cost that currently could have the psychiatric hospital of Trieste, which was closed in 1978. So I think it's sustainable, and it's been also, in a way, exported, not as a model, because it's not a model, it's more an experience. So it's a suggestion for a pathway, it's an indication of principles. But in other countries, you can go to Stockholm and you can find similar organizations, South Stockholm particularly. You can go to other places, particularly in Brazil, in South America. You find the law in Brazil was inspired by the system of called CAPS, which are community-based services, even with beds inside, as an alternative to hospitalization. And in many other countries, we also planned many times in the UK, starting from Birmingham in the end of the 90s, and then we went in discussion with other organizations, North Essex, and currently we have an experiment in course in Wales, particularly, and upcoming in York. So I think it's possible not to replicate, because it's such a unique number of circumstances that created the experience in Trieste, but try to take some of the principles. Probably the most important one is freedom first. The original slogan was "Freedom is therapeutic," but we can say now freedom is a sort of precondition. If you accept the positive risk of keeping the door open in the streets for the people coming in and getting out from the service, this is not just a symbolic metaphor. It's a real thing. People can use the services, get out of the system, and use it in a free way, and so they can experience to be considered citizens using services rather than patients and trapped in a system. This is the basic principle, and accepting this challenge on the part of the staff in co-production with carers particularly and service users, of course, it was probably the most important ingredient for the creation of this system. So I stop here because I think
Roberto, that's just a wonderful articulation in a very, very short period of time of an amazing achievement over several decades, really. And the points I think we'd love to come back to you are on this concept of freedom first. I mean, in England, we have been detaining more and more people under the Mental Health Act, which is something we really want to change. I think also what comes with that is the understanding of what type of society and community do we need to support this. And I think within services, what sort of training, we talk a lot about the Trieste model, and does that therefore mean that people need to be trained in much more negotiation skills, kind of social inclusion skills than we're currently able to offer? So what's the kind of the hardcore blood, sweat and tears the infrastructure that you need to make it work? So we will come back to you on that if we may.
Thank you.
Livia, could we hear from you? You've experienced both countries, both systems. Tell us a bit about what you think is good in both, but also what's missing that you, particularly with your perinatal speciality, want to see different, and how would you might want to spend some of Tim's money in every PCN on this.
Thank you so much, and I'm so honored to be part of this group. Thank you for inviting me. Actually, my Italian experience was rather brief because I finished my medical training and I did a bit of work in psychiatry as a medical student. Sadly for me, it wasn't in Trieste, it was in Milan at the time, but I was working a lot in outpatient services there. And then later, after a period of research, I came here to do the specialty training in psychiatry. And so in a way, strangely, I think I've got more familiarity now with the NHS, who has, been my psychiatric alma mater in some ways. And it was here that I first discovered the notion of perinatal psychiatry. And it attracted me straight away. And in some ways, I think that some elements of the concepts that both Tim and Roberto were bringing up in terms of culture and in terms of the importance of freedom and autonomy are echoed in the work that we try to do in the perinatal world. First of all, because there's some great emphasis on prevention, which is by no means unique, but certainly not the most common element of working in the NHS. So a big part of what we focus on is preventing relapse, and we are in a rather unique position of knowing that there are specific risk periods where all our efforts need to be focused on, so that we can do that work and minimization of risk and early detection and fast treatment, with a goal of keeping people in the community. I work in a perinatal community service that also has a liaison component with maternity. And the biggest reason why we know that this is really important is because there have been now many confirmations, including financial confirmations from studies done by the London School of Economics, that untreated maternal mental illness has massive repercussions, which mostly are for the infants and their future and their development and their trajectory in life. And treating maternal mental illness is what will offer these children a much greater chance at a healthy development and future. So the importance of early years is very much integrated in the conversation with women's health and maternal mental health. And in a way, our sense of trying to bring psychiatry into other aspects of people's lives has to do with the integration with maternity services. So a lot of perinatal services have got either some clinics or a basis or a presence in maternity outpatient clinics, trying to be part of women's maternity care, so that there's a sense that we are part of a holistic care plan, that psychiatric complications in a woman's journey to motherhood are complications like they would be in any other sphere of medicine, and they need to be integrated in their care. And at the other end, we want to integrate with more psychotherapeutic processes to help women develop a strong relationship with their babies, to keep families closely together. The arrival of a baby, wonderful as it is, can also be a bit of a bombshell for a lot of families, and sometimes brings up perhaps old wounds or difficulties. It highlights problems in the couples and in the families at times that may require some input, which we try to give, working as together as possible, so that women feel and families feel that they can take several aspects of their care and bring them together. And this has been framed as a notion for us as something called the perinatal frame of mind, where we never just focus on the health of one person. Our focus is split always between the health of the mother, a healthy development of the infant, and the health of the relationship. So we can only exist in a way, in a social sense, because a fundamental focus for us is how relationships form and develop and are built, and how people can construct their own narratives now that they need to help someone build a new narrative from scratch. And part of this narrative must be autonomy. So I think I never really thought of it that way exactly, but what Roberto mentioned before about freedom being a fundamental pre-existing element of care is absolutely essential. And I think here what I found in the UK is that there is a huge emphasis on autonomy and personal freedom. It's really, really important to people. But somehow, sometimes when it comes to psychiatric care, it gets a bit sidelined. And for us, we work very hard at trying as much as we can to give women the chance to have agency over their care because they are at a unique moment in time when they have to make potentially very complicated decisions. So it's important that, so far as it is possible, that they are confident and comfortable with these decisions. If that can't happen, there have been cases where we've had to agree with women that they should be in hospital, and when that happens, it's ideally a specialist unit where the ethos remains the same, a mother and baby unit. There have been occasions, which I think in the perinatal world are fairly rare, where we also detain people who are too unwell to make their decisions, to choose about their care.
Livia, you have given us just a wonderful, a wonderful vision of the future, and your passion for mothers and children and the wider family communities absolutely shines through. Can we come back to you about the issue of who at the end of the day still do people feel need or would benefit from being detained in perinatal beds? One of the issues that you touched on, which is very dear to my own heart, which is the whole issue of prevention, because the very best mental illness and the very best crisis is one that hasn't happened because you've been able to prevent it. So I want to now hear from George. So George is a liaison frontline junior clinician, experienced, but still at the start of his career. And George, what we are often told is that, 57% of people who end up in a hospital bed, certainly in our kind of urban areas, have unstable housing. They don't have a place to really go back to that's going to be a permanent home. That for mother and baby units, 80% of the people that end up detained in perinatal units are actually people who have already had episodes of severe mental illness, but haven't got access to a care plan with advanced decisions, with perinatal medication advice helplines, with exactly the sort of support that Livia was talking about. You're working in liaison psychiatry. How often at the moment in your current role are you seeing people whose pathways into the system could have been helped at a much earlier stage? If Tim's 1.3 million had been invested in the local perinatal, the local PCN services, did the people need to get to the stage where they ended up in crisis and then ended up seeking help in A&Es and with the potential for some of them to go on to be detained and admitted under the Mental Health Act? So George, do you want to give us a bit about your 7 years in the NHS and what you've encountered as a junior and how it plays into this debate about, have we got the plans for community services right for the future? How will we make it work?
Sure. Hi, everyone. I'm Georgios Basdanis. I'm Greek originally, have worked in the NHS for 7 years now. Initially in the north in Scarborough and Tees and Webb Valleys for 18 months, and then in South London and Maudsley, where I did my core training, and I'm now doing my higher training. Throughout training, I've rotated in sort of every service along the pathway of a patient. So community, home treatment team, inpatient, and liaison. So I've sort of come to understand the pathway and the challenges a bit better. I think I completely agree with Geraldine in terms of we often see people that have reached the point of crisis because we're not dealing with problems upstream in terms of in community services. They're quite stretched. Care coordinators are not able to see people often enough and that sort of thing. Also, I was part of a CMHT when we went through the sort of local restructure and merging of teams, and I saw how difficult it was to recruit staff into CMHT. So that's also an issue in terms of finding enthusiastic people to work in those teams. Housing is a big issue. And when I was reading about the Trieste model, I thought, well, wait, we can't really enforce that exactly. And I think I was reading one of Roberto's papers from 2014, which said that the sort of population in Trieste was reducing and there was sort of more housing available where mental health could plug people in really quickly. And I think with housing, that affects people showing up in liaison and crisis, because if they're homeless, you have nowhere to home treatment. So the only option is then admission. And also people that end up on inpatient units are then stranded or super stranded because then you're waiting for housing, or they go to unstable housing like a B&B that, cannot really help them recover from their mental health. In terms of the investment that Tim spoke about in the NHS long-term plan, it sounds amazing that we're investing so much in our community services, because I think, as I said, we can catch a lot of those issues before they get to a crisis point. I'm less optimistic maybe about the number of beds that we can reduce just because of all the social issues I talked about. We're then left to rely quite a lot on hospital beds. Also, being Greek, and I presume it's similar to Italy, social networks are very different, families are very different. The amount of support that you can expect from your social network, I think, is probably less, I would say, in the UK. So it's a very different patient population, and their support network is different. So I'm just kind of mindful of the fact that, we are reducing beds, and then what happens is people will stay in an acute hospital in A&E for 48 hours waiting for a bed. And then that sort of becomes an issue in itself. It's also really great that we're putting money into services like perinatal and more specialist services, but also I'm quite mindful that we also need to keep the sort of catch-all CMHT in mind, if you want, because I think then we run the risk of this two-tier system of services that are very specialist, like early onset psychosis or perinatal services, with then the sort of generic CMHTs kind of being left to their own devices. And the only other thing, yes, that we mentioned, Geraldine, was just having been here for 7 years. Obviously, I don't have the experience of other people, but in the long-term plan, there's ideas for things like crisis cafes or 24-hour, 7-day-a-week crisis services. And I've heard from my consultants and other people where I work that those things used to exist. We had 2 home treatment teams in Lambeth where I work that used to be 24/7, and now they've merged into one that's 8 a.m. to 10 p.m. So I'm sure we have that knowledge from before. What worked well in the crisis cafes? What worked well in the 24/7-hour home treatment teams? Why did they close down? And now that we're planning to reinvest and reopen them, how can we do that better, I guess, learning from our past experiences?
Great.
Sort of quick.
That's absolutely terrific. Really appreciated. So can I turn to some of the questions that have been kind of raised? And we thank you so much, everybody who's put questions into the chat. There's almost too many for us to be able to answer them all, even in the next kind of 25 minutes that we have. But some of the questions that are coming up are, what would we need to do that was different in our society, rural and urban, that could help either recreate or learn from the culture in Italy and Greek, where perhaps families are more involved? I mean, one of our big challenges in England has been the identification even of families and carers, and the involvement of families in care, and actually seeing them as part of the solution, not part of the problem. So that's kind of one question. What do we think we need to do societally? Do you have a different system of local government with different cultures in Trieste, in Italy, perhaps in Greece? And I think the second thing is the big challenge of, what do we do to get from where we are today to where we want to go How do we make it happen in a way that supports staff to have the courage to do this? I am hugely proud of the rapidly growing number of health and social human rights champions that we have in South London and Maudsley and across South London. But how do we support them in a culture which has significantly in the past not been friendly to people that have taken the kind of innovation risks? I don't know whether, Roberto, you want to answer that, or Tim, you want to kick off?
Don't mind, I can give it a go.
Lovely, thank you, Tim.
Insofar as I understand what you've asked, I mean, first thing about families, I absolutely agree that families are part of the solution. They, and I know that the extent to which we have excluded families, and I have relatives who use mental health services, and I am utterly excluded from conversations with those mental health services. And that's as the National Clinical Director, makes no odds at all. So I think that they are really, really important, and we wouldn't be at loggerheads with families half as much if we involved them from the start. I think the more serious a mental health problem, the more it affects everyone around them. So that's the first thing. I think the how do we get from where we are now? Okay, well, one thing, and I think Roberto's already referred to it, freedom first. I actually think, I mean, I've sectioned, I think, less than 10 people in my entire career. And I've worked in acute settings, and last decade with homeless people, almost all of whom have got either psychosis or very severe personality disorder. And I've always taken the view, make it as collaborative as you can, and be willing to wait, and be willing to take risks, and don't do stuff like assess people's risk and think, oh, they're low risk, we don't need to help them. It's a mistake to do that. I understand that there are problems with resources, but that's why now is such an important time to talk about these things, because there's so much resource going in. And the perinatal stuff, for example, we put loads of money into perinatal services. So those are my first shots at it. Happy to come back. Roberto?
Yeah, well, I think I don't want to overemphasize the discourse about the different social circumstances and organization of in Italy and Trieste. Also because Italy is not anymore. I have to give you a bad news. Family is disrupted also in Italy. It's not, and Trieste particularly has 1.9 is the average of a nuclear family. So this is the number of the members. So we have to reconstruct a social network around the person and social supports of any sort. What was unique? This is one of the questions. I think, well, of course, the families, the first maybe 10 years, I will cut the thing in a very rough way, but for the first 10 years, we worked against families. Even if Basaglia used to say that we must be close to those that we abused, sending people back in the community, it was a very difficult situation. Then we realized after maybe 10 years that we should have a better alliance also with the families, not just defending the patient. And so this was a very important step, and families are expressing their needs, their burden, and were involved in care, and they started to be allied. And Italian reform has been saved by family organization. That's a very important historical datum. And about the uniqueness of Trieste, I would like also to say that it's what was unique was not just the quality of the leaders and that I work with, but also the motivation, because we were struck to work to demonstrate that we can do without an asylum. And this was the main motivation. So we did everything to demonstrate that. So we were very active, we're proactive, assertive, engaging people, going there and try to develop alternatives to everything, including this kind of work opportunities, supported housing, etc. So it's so you can expect that doing this way, you must be very close to the communities and to the clients, and you can reduce the level of coercion because people can feel that you are together with them. Also, when you have negotiations, strong negotiation, difficult situation to manage, etc., etc. So I stop here for a while.
That's really, really helpful. Livia, one of the questions that's being posed in the chat is someone who's saying, what type of people do you think it's justifiable or necessary to still detain under the mental health and bring into a perinatal unit?
Well, I suppose for me too, using the Mental Health Act is fairly rare. Most of our work tends to be collaborative, but the parameters, I think, have to do largely with people becoming so unwell that they lose the capacity to make decisions about their care. It could be because they become psychotic or because they are profoundly depressed. It's not just an issue of risk management. It's also an issue of sometimes needing for a brief period of time, intensive care input in a specialized setting, more than what the community can provide, and a chance to focus exclusively on caring for baby and developing a relationship with baby while getting better. So these would be the circumstances when an inpatient admission is valid, or when we can tell that our intervention in the community will actually not be enough. And we, again, don't want people to get to the point that they're so ill. We want to be sure that they stay in hospital less, and if they go sooner and have that intensive input, it will last for a shorter time. It's never an easy decision, but sometimes it's the right thing to do. And most women actually decide to go voluntarily after a discussion with their partner.
Great, thank you. So Tim, I know, is a huge champion of integrated mind-body care, and I love his phrase, no wrong door and kind of just one door. So some of the questions coming up in the chat reflect that. So the questions are really about what are the implications of having more care in the community and primary care? Would that likely, and in closing, mental health hospital beds? Because we've certainly got a situation where our data for the whole of London tells us that the majority of people who have very long waits in ED are people who are mentally unwell, but the flow into securing them, either accommodation or 24/7 crisis services or an inpatient bed if they need it, that's kind of the big problem. And they are the people who report really difficult experiences sitting in A&E waiting for the next stage. So George, you are a liaison mental health person. And I mean, in many ways, the whole driver of the 5-year forward view, long-term plan and the policies before has been about trying to reintegrate mind and body. So Livia is clearly working in an integrated mind and body physical health way in perinatal. Our liaison teams are in EDs on the wards. Roberto mentioned having beds, 6 beds in general hospitals as one of their ways of offering better support to people with mental health problems. What's the insights you gain from who comes to ED? Are they frequent attenders? Are they people who stay a long time? What could we do? Are there more people presenting in crisis because we haven't got the day centers we had?
I mean, in Liaison, and if we focus exclusively on ED, because we do the work with people who are inpatient for physical health and also happen to have a diagnosis of ill mental health, which is not what we're talking about, I guess. In terms of who's turning up to ED, I guess you have a cohort of people with complex emotional needs who might be attending more frequently in crisis and who might have frequent attended care plans in terms of discharging them quickly. And then you have, I guess, a cohort of people, as I said, that we identify just by reading the notes. Maybe they're open to a community mental health team and they're only seen once a month maybe, and that doesn't really contain them. And they sort of, for some reason, for whatever reason, stop their medication and then show up to A&E in crisis. And I think we saw quite a lot of that with COVID, because a lot of the contact was not face-to-face. And I think that makes a whole world of difference in terms of, I think at the time of the first lockdown, I was working in a home treatment team, and even most of that was over the phone. So there was very, very limited face-to-face contact. So I think there's certainly a lot to be done. I think if we sort of, increased our community offering, I think we could pick up a lot of these things earlier. But also, having worked in community, you have people that, disengage from treatment and don't want to work with you, even in early onset psychosis where we had the resources to assertively sort of engage them. And for those people, I'm not then quite sure what we would do if we sort of completely adopted the Trieste model and sort of completely did away with inpatient beds and the use of the Mental Health Act. Then it's that cohort of people that I'm not quite sure how we would capture.
Could I perhaps just quickly answer that, Geraldine? We keep an eye on people who are spending more than 12 hours in A&E. And I would say on average, it's a horrifying 2 to 3 patients in every A&E every week spend more than 12 hours in A&E. Terrible. Now, when I say on average, it's actually the same places, and it's the same 25% of trusts that have big out-of-area placements also have long waits in A&E. And when you go to those trusts, they say, we don't have enough beds. But actually, we've looked at this quite carefully. It's got nothing to do with how many beds they've got. It's to do with how they use their resources first, and second, that is how they use their beds. And secondly, is what sort of community services they've got. And the better the community services, the less likely this is going to happen. Now, it is worth saying that when Roberto says they've got 6 beds per community mental health centre, that's 24 beds. So plus the 6 in the inpatient, that's 30 beds. Now, in Sheffield, we operate on pretty much that number of beds. The difference is that we use much more coercion because they're inpatient beds rather than, staying out in the community and having, when these community mental health centres are a fantastic community resource. They're a place to go where families can go and people can drop in. So I actually think if you do that kind of thing, you get to the problem a long time before we do.
Yep. So I've got lots of questions from Sir Norman Lamb, questions from David Bradley, our chief exec, questions from many of our experts by experience. I'm just wondering, going forward, and everybody is saying this is great, absolutely great. We're kind of up for really, really working on this. I think it's more the how do we train people? How do we train society to accept some of the risks if we don't detain people? Because that's not a pattern we have. How do we change from what we've got to what we are? How do we think we can best help people?
Can I say, I'm going to ask Roberto if he could say something about this. When I went, I've been to Trieste 3 times. In 1986, when I went, that was that was 8 years after they'd shut the asylum, And I remember Roberto saying to me, because I followed him round, trying to understand what people were saying. And I remember him saying there were two types of nurses, or two within their services: those who had grown up in the asylum and those who'd grown up outside. And it was like two entirely different cultures. And I do think that's the nub of what we're going to end up getting to. Is it's a real cultural change that's got to happen, and it's as much in here as it is out there. Sorry, Roberto should be saying this rather than me.
Roberto.
Sorry, Gerald. Can you repeat the question, because I...
So the question is really, people are very keen to change. I mean, there's no doubt more and more people want to see our model in England being different. But in people's heads, people are anxious about, they haven't got the training to persuade people to come into, to accept care. They haven't got the negotiation skills. Our society can be very punishing of people who are seen to not have taken due care. And that was one of the backlashes that almost stopped community care from ever happening in England in the first place. So what culture? So we need to help people change their attitudes, change the culture. We need society to do the same thing. What advice would you give us about how to kind of set about that?
First of all, I have to mention that we set up with the purpose of expanding the best experiences in community mental health care about 20 years ago, under the umbrella of the World Health Organization initially. This International Mental Health Collaborating Network, which has a website. I suggested in the chat to have a look, because we used the instrument particularly developed by my friend John Jenkins of so-called twinning collaborations that are where 2 or 3 organizations twinning together and work together to create a common plan for change. And Trieste was engaged in that, and Trieste had a lot of advantages from these exchanges, and we evolved through the years, also thanks to the input that came from the UK. Last but not least, the recovery house, the crisis teams, etc. So there was a great exchanging experience. It's very important. So getting out from the concept of being isolated in your country, in your place, in your region. This is the same in Italy. It's not because UK has done the Brexit, but this is the rule. So people feels to be. But we have similar challenges all around the world. We learned a lot from Indian experiences in Chennai, from the Banyan, for instance, about intervening with women with schizophrenia, which are homeless in the streets, and reconstructing their career as citizens and accessing them to work, etc. So I think the best way is to create the possibility of looking at different practices, but also I believe that the practices have their own strength. So we must believe that doing an innovative practice must be attempted. And doing a practice, you have also at the same time change the mindset, your mindset, learning from the others, and not relying just on changing the institution, changing the structure of the services. This is not enough. We know this very, very, very much. So I think this is some of the principles that the MSCN is using and adopting. And also in the recent years, the importance of the stakeholders. So we can't do a change, not just because we didn't engage the politicians or the policymakers, the decision makers, but also because we were not able to engage in many parts of Italy carers, service users, active members of the citizenry, etc. So I think it's important to create this movement, and there are methodologies to do that, creating groups of stakeholders, discussing the process of change, starting from the roots, from bottom up. I think this is very important.
Worth adding, one thing about this, Geraldine, is out in Trieste, one of the things that they are very good at is thinking about the micro politics of change. Yeah. So they are thinking sort of sociologically at the same time as clinically. And I think one of the sort of barriers that we're going to come up against is this ingrained attitude to risk that, you know, if there is a risk, we've got to put the brakes on, we've got to contain them, we've got to put them into hospital, we've got to, because otherwise, you know, everyone will blame us. And I think that's one of the key things that we're going to have to face.
I absolutely couldn't agree more. And I mean, I think the questions that are coming up in the chat are great. I think every one of them deserves thinking about an answer. And I don't know whether that, you know, we could have a national repository of questions where we could just try, because nobody will have the absolute answer, but just we could hear what people's concerns are, because I think that will help us understand culture change. Livia, can I just ask you, just because we're almost just one quick sentence from you, if it's possible, what will you do going away from today to take forward this whole principle of we're moving more into a community population prevention space?
I think it's been said probably better by Tim and Roberto, but I think the emphasis needs to be on us trying very hard to make people well rather than just not ill. Because if they're not ill, it's going to be much easier for them to become ill again. Yeah. Being well means feeling that they have a rewarding and functional life. It's very hard because some of the people that we see do have very deprived, complicated, painful lives. So it can be a very long journey.
Beautiful, beautifully articulated. Thank you. George, you have your whole career ahead of you. What do you take from today? Just one sentence as we come into the close.
I think what I'm reflecting on, and I think this was picked up by David Bradley in the chat, is our use of the Mental Health Act and our response to risk, as Tim said. I think coroner's court is a trigger word for every trainee in psychiatry at the moment. And, you know, the question, is there a Daily Mail in Trieste? You know, can someone get plastered on the news for letting go one person from A&E that went on to do something bad? I think drives a lot of our clinical decisions. I think we are risk averse and we're becoming more risk averse. And I wonder whether that's reflected by society that's sort of mirroring the US more and more in terms of being more litigious. So I wonder how we can educate, well, both ourselves, our senior clinicians, but also new doctors in terms of getting freedom first, not using the Mental Health Act to the degree that we're doing, and kind of turning things around, I guess.
And maybe to do one thing that Franco Basaglia said, at least I think I'm not misquoting him, is it's not, we don't need more therapeutic communities. We need to make communities therapeutic.
Perfect.
That's good.
Thank you so much indeed. You have been an absolutely fantastic panel. We could have gone on for at least another half an hour. I'm so grateful to you all for coming, and I hope you've enjoyed the experience and find it useful and helpful. And this is the end of this episode of the Challenging Conversation panel. Thank you so much indeed for everyone who attended. Take care.
Thank you very much.
Bye.
Bye.